Hello, my name is Daniel Fulkerson. I'm an associate professor of neurological surgery with the Indiana University School of Medicine and the director of pediatric neurosurgery at Beacon Medical Group with Beacon Children's Hospital in South Bend, Indiana. This slideshow is an addition to the chapter entitled Pediatric Vertebral Column and Spinal Cord Trauma. I have no disclosures relevant to the chapter. The objectives for this talk are to discuss injuries specific to kids. We'll also discuss management in treating patients with spinal injuries, and especially the problematic challenge of clearing the cervical spine in a child. Spinal injuries are relatively rare in children. Of all the spinal injuries treated, only about 4 to 14% occur in pediatric patients. When children get to be about 8 years of age, the pattern of injury is about the same as adults. For any kind of given injury, children have a higher mortality than adults. However, children also have the chance of recovering much better. An adult with an injury with complete loss of function below the level of the injury is very unlikely to have any benefit, unless there's a structural lesion that can be treated immediately. Children, however, can recover from injuries that may completely paralyze an adult. There are a number of anatomic differences in the growing pediatric spine. The facets are more horizontally oriented, and the uncinate processes do not ossify until about 10 years of age. This makes the cervical spine a lot less resistant to rotational forces. Children are also basically a bobblehead doll. They have a large head on top of a small, weak neck. Therefore, the fulcrum of motion is higher than an adult who has a more developed muscular structure of the neck. The fulcrum of motion is higher, and therefore children suffer a higher level of cervical spine injury. The most commonly fractured or injured bone in a child is C2, compared to a lower subaxial bone in an adult. Initial evaluation of a pediatric trauma patient is the same whether they have a spine injury, head injury, or both. The most important thing is to stabilize and resuscitate with the recognition that the patient may have an unstable spine injury. It's very important to note the mechanism of injury and the neurological status. Unexplained hypotension may be an indicator of a spinal cord injury. Children have a large head, and therefore placing them on a flat surface will somewhat flex their neck. This may be suboptimal if a child has an unstable spine injury. This is particularly in infants. Therefore, when one is transporting and stabilizing a child, there needs to be consideration for this fact. There are a number of boards that are made specifically for children that allow the head to fit in a recess and therefore stay in a more neutral position. If one of these is not available, then placing a set of towels or some sort of buttress underneath the body may keep the neck in a neutral position. There are a number of pediatric orthoses, even for the smallest of children, that are commercially available. Any hospital that is dealing with a lot of pediatric trauma should invest in these kind of equipment. Imaging of a child is a little bit different than an adult. 11 to 34% of children will have multi-level involvement, and up to 7% will have non-contiguous injury. It's very important not to be focused on one injury to the detriment of looking at the entire child. If a child does have a definite spine injury, it probably behooves the doctor to image the entire spine. One other thing that's very important in children is to keep a high suspicion for non-accidental trauma, especially in infants. If a child has shaking, they may have damage to the upper cervical spine. And this is something that should be highly suspected because it may be quite difficult to diagnose. Adults have a fairly accepted method of clearing the cervical spine. In other words, of determining by clinical examination that x-rays or imaging studies are not noted. This is based on a large study called the Nexus study. It's important to know the limitations of that study in regard to pediatric patients. Only 9% of the 34,000 patients in the study were less than 18 years of age, and very few of those were less than 8. People have tried to retrospectively apply nexus criteria to children. Over about 8 years of age, the nexus criteria is very reliable. However, the younger one goes, the less reliable it is. Clearing the cervical spine is quite difficult in a child because one needs to balance the fact that there's maybe a lack of communication due to age. Child may not be cooperative or quite afraid. It's important to keep a high level of suspicion in certain mechanisms of action, including non-axial trauma, falls from a height, and motor vehicle accidents. One wonders what is the best way to image a patient. X-rays may be fairly unreliable in a young patient, especially one that has very little ossification or an infant. Children also may have significantly unstable injuries without a fracture. Adults with major trauma will often fracture the bone. Children may tear ligaments and have normal X-rays. X-rays are also fairly limited in the upper cervical spine. CT scan is better, however, a CT scan exposes a child to ionizing radiation. There's a growing concern about the possibility of causing cancer with CT scans. A number of papers have applied mathematical models and actuarial data to the radiation exposure of a cervical CT scan and a CT scan at other parts of the body. One may wonder if this is actually applicable in the real world. However, clearly there is some risk of developing a future malignancy with CT scanning. MRI is also a modality that gives us a great look at the ligamentous structures and the disc structures of the spine. It also gives the best look at the spinal cord and the nerve roots. However, an MRI takes time, cannot be done with metallic objects, and involves putting a potentially unstable clinically patient into a hole for an extended period of time. Therefore, any attempt at clearing the cervical spine needs to balance the ability to try to minimize unnecessary tests and therefore unnecessary radiation, also to try to reduce the time spent in unnecessary immobilization, while still detecting all injuries. The Pediatric Cervical Spine Clearance Working Group is a multidisciplinary panel of experts who put together an algorithm that's considered a, quote, best practice, end quote, consensus statement regarding the challenge of clearing the cervical spine in a child. This panel consisted of 15 orthopedic surgeons, 3 pediatric emergency medicine specialists, 3 neurosurgeons, 2 trauma surgeons, and 2 radiologists, all with expertise in pediatric trauma. The consensus statement was based on survey data and then face-to-face meetings to try to arrive at an agreement. This is presented here and is published in the Journal of Bone and Joint Surgery in 2019. The algorithm divides patients, regardless of age, into categories based on their presenting Glasgow Coma score. A child with a score of 14 or 15 is at low risk for having a spine injury, and one may aggressively try to clear them clinically. In this group, the initial imaging study of choice is a lateral X-ray. A patient may be cleared clinically even if they have developmental delay, as long as one has sufficient expertise and comfort level in treating those children. The group also recommended a spine consult service that may be comprised of people with expertise in the field. If a patient is unable to be cleared clinically, this service should be consulted to make recommendations of further imaging studies. Patients who have pain that is not in the midline may be cleared clinically. Patients that do have pain may have an option. If the patient is cooperative and the physical exam findings are normal, one can consult the spine service. One can keep them in a collar and reevaluate in 2 weeks, or one may obtain flexion extension radiographs. Patients who have a GCS of less than or equal to 8 are considered at higher risk for a spine injury. In this group, the initial imaging modality is CT scanning. If the patient is in such a manner that it is unlikely that they are to be either awake or cooperative within 72 hours, MRI is suggested. If the MRI is normal, the cervical spine can be cleared. If the child is likely to wake up and be able to participate, then one could do repeat clinical examination. In any event, these patients should be evaluated by the spine expert team. Patients with a GCS of 9 to 13 are considered intermediate. In this case, plain radiographs are still recommended, and they have similar protocols to the GCS 14 or 15 group. The authors acknowledge that some of their recommendations are controversial. One of the controversies regards the use of x-rays. There are papers that show that flexion extension x-rays are somewhat unreliable in a child. One would need to have very good participation in a child old enough to have this be valid. One also questions the use of x-rays in an infant. The authors do recommend that a high index of suspicion should be maintained for non-accidental trauma. And in these cases, an MRI is recommended. No protocol will universally find every single injury. No protocol will be perfect, and there may be studies that, in retrospect, are not necessary. Therefore, it is very important for the person treating a child with a spine injury to be very meticulous regarding their examination and their judgment. In my opinion, one should never hesitate to order the appropriate diagnostic test, despite the concerns about radiation. The immediate concerns of missing an unstable injury, in my opinion, outweigh the concerns of future problems. Given that this is a consensus by a group of experts in the field, I think it is quite reasonable to use this as a base for algorithms in your own institution. There's a wide belief that algorithms for clearing the cervical spine are necessary. However, in 2017, a study of Level 1 pediatric trauma centers showed that less than half had a defined algorithm for clearing the cervical spine. The listener is encouraged to read the article with the citation below. In evaluating a child, it's very important to recognize normal variants. Many children will show pseudosubluxation, which is a physiologic offset of usually C2 on C3. This can sometimes be overread as a sign of a dislocation or subluxation. Patients that move generally do not have pain. This is a normal finding, and the spinal laminar lines remain intact and smooth in flexion and extension. Evaluating patients with cervical spine injuries, it's very important to know the injuries that are somewhat specific for children. This is a case of an 11-year-old who was involved in a high-speed motor vehicle accident and a prolonged extrication. The patient was unresponsive at the scene. Therefore, the index of suspicion for a serious injury is quite high. Patient underwent a CT scan. In one of the lower cuts of the CT scan, there's a significant amount of hyperdensity around the lower part of the brainstem. This is often an indicator of injury to the tectorial membrane, which is the main stabilizing membrane of the craniocervical junction. There are a number of ways to evaluate this. One first notices on this CT scan that there are no bony fractures. However, on close examination, the distance between the basion and the top of the odontoid is longer than it should be. This is an indicator of the possibility of atlanto-occipital dislocation. One can also measure the ratio between the basion in the back of C1 and C1 in the back of the foramen magnum. These are potentially useful measurements for the devastating injury of atlanto-occipital dislocation. Here we measure this ratio, and this is the well-known Powers ratio. Powers ratio here measures BC and OA. If the ratio of BC divided by OA is greater than 1, one must consider the possibility of atlanto-occipital dislocation. It's normal if it's less than 0.9. Normal Powers ratio does not exclude the injury of atlanto-occipital dislocation. AOD can have three forms: dislocation anterior, distraction, or posterior. Powers ratio may be normal in the latter two. Therefore, another important measurement is the measurement of the condylar C1 interval. This measurement is done by looking at both a coronal and a sagittal CT scan. One then takes 4 equidistant points on either slice and averages those. Here we can see the sagittal finding that looks quite wide. If the average is greater than 4 millimeters, one should suspect atlanto-occipital dislocation. We can see an example of that here. This was reported by Pang and had 100% sensitivity and specificity for atlanto-occipital dislocation. One should also evaluate for asymmetry. And here is a cartoon looking at 4 equidistant points, again looking for an average of normal being less than 4 millimeters. MRI shows very good detail, and in this case one can see actual avulsion of the tectorial membrane. In this case you can see also significant myelomalacia hyperdensity in the spinal cord itself. This is another example of a child in a high-speed motor vehicle accident. The CT scan does not look terribly unremarkable. There are no bony fractures. However, the lower part of the cranial CT scan shows hyperdensity in front of the cervical cord. This is a tip-off for ligamentous injury. In a younger child, an unstable injury may come from disruption of the ligamentous structures more so than bony fracture. And again here we see in the same child a complete avulsion of the tectorial membrane. These are highly unstable injuries. These are injuries that need surgical fixation. There are a few options that one can do. One can put a child in a halo. However, halos have a high risk of failure. Therefore, operative fixation may be preferred although this may be challenging in an infant. Stability of the head on the neck is mainly due to ligaments. Fatalities occur from respiratory arrest. These are extremely unstable injuries. In evaluating the treatment, one catastrophic mistake would be to place them in traction. This would likely lead to a high risk of neurologic deficits. Observation is likely not a choice, as these are highly unstable injuries. Halo may be a reasonable choice, although these have a high complication rate in children, and they have a high failure rate in this particular case. Therefore, surgical fixation should be strongly considered if at all feasible. This is another case. This is a 5-year-old healthy child who had a minor fall, then began to complain of neck pain and refused to move his neck. These scout images show the very characteristic cock-robin position, looking like a bird looking to eat a worm. The head is tilted to one side, rotated to the other, and slightly flexed. CT scan will show abnormal relationship of C1 and C2. This is another injury that's relatively unique to children, and this is atlantoaxial rotatory subluxation. Child cannot move the neck if they are still subluxed. One can try to brace this, but one should not force it in a neutral position. This injury can occur with relatively trivial trauma, and one should suspect this in children who have a ligamentous laxity, such as kids with Down syndrome. If one puts them in a collar that provides a little bit of upward distraction and gives them muscle relaxers, this will generally reduce spontaneously. In my personal experience, I have yet to have to operate on one of these. Every single one reduced with a collar and muscle relaxants. Most are neurologically intact. If one does have a deficit, this is concerning for a potential vascular injury. Once they're reduced, they generally heal well in a collar for about 6 to 8 weeks. If a child has been subluxed and out of joint for greater than 3 weeks, there is a very high rate of failure with the collar. In that case, they may need fusion. Surgery is considered if one is unable to reduce the injury, if there is progressive deficit, or if this is something that keeps recurring. One of the things that is often looked at is the possibility of normal movement on C1 and C2. Sometimes this may be a little bit overdiagnosed, and therefore it is very important to understand that there is normal rotation of C1 on C2. Over the first 23 degrees of rotational movement, C1 moves and C2 stays stationary. Therefore, if a child lies a little bit asymmetrically in the CT scanner, C1 may not perfectly align with C2. This may be normal. A child who's truly subluxed cannot move their neck, and therefore clinical evaluation is important. This is another injury specific for children. This is a 21-month-old who was involved in a high-speed motor vehicle accident. Patient CT scan shows that they have a skeletally immature spine, as expected. The C2 bone has a number of growth plates and growth centers. The base of the odontoid is the odontoid synchondrosis. This normally does not ossify until a child's about 7 years of age. This is a particularly weak spot and may be subjected to an injury. In this case, one can see the odontoid process slipping off the body. This is different than a type 2 odontoid fracture in an adult. In that case, the bone is actually fractured. In this case, in an infant, the odontoid synchondrosis basically slips. This is an injury particular to kids under 4 years of age. Because there's not a fracture and it's a cartilaginous slip, it will actually heal quite well if one can get it into alignment. And the usual treatment is halo fixation. This is considered conservative treatment, and these are a number of papers describing this. However, if one looks at that data, there is a very high risk of failure. Of over 10% have progressive deformity, and there's a very high rate of complications with a halo, especially in a younger child. Therefore, surgery can be considered in patients with a select group and constellation of injury. The advantage of surgery is it spares the halo and has immediate stabilization. Technique is fusion of C1 to C2. Times where we recommend surgery is if the injury cannot be reduced, if there's significant angulation or significant displacement. If it can be reduced, then it may heal well with an external orthosis. Older children and teenagers have injury patterns that are fairly specific for adults. This is a patient with a fracture through the dens. This is one, much as an adult, seemed to be an ideal candidate for an odontoid screw. Patient healed quite well, and by doing an odontoid screw, preserved all of her range of motion. An injury that's more common in children but not specific for children is a true teardrop fracture. There are a lot of times where one will get a small avulsion over the anterior vertebral body. This is not an unstable injury and can generally heal in a collar. However, a true teardrop fracture is an avulsion with injury to the surrounding structures and looks like a teardrop off the anterior vertebral body. Key to this is there's subluxation of one vertebral body on the other. In this case, the MRI shows a large hematoma anterior to the injury and shows significant damage through the disc space. This patient had a severe head injury and was not suitable for surgery for a long period of time. Therefore, they were treated with a cervical collar somewhat by default. This X-ray demonstrates the instability of that injury, as one can see progressive kyphosis in the upper cervical spine. Therefore, once the patient was clinically stable, they underwent a posterior instrument fusion with good restoration of alignment and complete healing of the injury. Another patient with a similar injury but who was not in quite as bad a clinical shape underwent an anterior procedure with very good results. A true teardrop injury is biomechanically unstable, and we would recommend cervical instrumentation and fusion. MRI can be quite helpful in trying to distinguish a true teardrop fracture from a small avulsion injury. Another clinical scenario that is relatively unique to children is the finding of skiwara, or spinal cord injury without radiographic abnormality. In this case, an 11-year-old wrestler was driven into the mat and immediately felt like they could not move their arms or legs. Images, by definition, are normal. Patient strength and sensation returned over 1-2 days. One of the unique characteristics about this injury is the kids seem to be remarkably nonchalant about it. They seem to be very calm and seem to know that they're going to get better. Younger children are quite flexible. The spinal column of an infant in a cadaver study may stretch up to 2 inches without any damage to the bones, ligaments, or disc. However, the cord itself can only stretch about 1/4 of an inch without damage. Therefore, one can stretch the column, stretch the cord, and not have any injury that one can detect when this was described primarily on X-ray or CT scan. This may be a little bit of an out-of-date term now with the routine use of MRI, where findings generally do occur. Dr. Pang also reported this and recommended bracing for 3 months to prevent late deterioration, and felt that aggressive bracing put someone at less risk of recurrence of symptoms. Others have questioned this and wonder what's the use of bracing if the images are, by definition, normal. If there's not truly a structural injury or biomechanical instability, is keeping someone in a brace truly beneficial? Now with an MRI, one generally can correlate some injury focus with the clinical findings. As expected, if the patient has significant damage to the cord, hematomyelia, or cord disruption, they have a poor prognosis. Most patients do not have that. Patients that have fairly normal MRI generally have a complete recovery. Children take a fairly significant amount of injury to injure or fracture the thoracolumbar spine. One of the things that's important in evaluating the spine is to evaluate the whole child. There are very minor injuries of the spine, such as transverse process fractures, which rarely require any intervention. However, they may be a marker of significant abdominal trauma. It's therefore imperative to have a comprehensive trauma service evaluate children with serious injuries. The TLIC system, or the Thoracolumbar Injury Classification and Severity Score, is a consensus statement that has become fairly well established and accepted in the adult spine community. This evaluates patients based on the shown factors and basically recognizes the importance of the posterior tension band. One generates a score, and this can help decide if one should operate or not. A score of less than 3 will generally heal without surgery. A score greater than 5 is operative. And clinical judgment is required for 4. There have been a few studies that have correlated the TLIC score with decision-making in children. While it is not nearly as robustly studied as in adults, it does provide a fairly good guide that one can use in evaluating a child. Thoracolumbar injury that is fairly specific to children is a hyperflexion or seatbelt injury. This is a chance fracture. One can see the fracture line through the pedicle of L2. This is usually from an improperly fixated child with a lap belt. One of the important things with this injury is there's an extremely high rate of abdominal injuries, including injuries to the duodenum, spleen, and kidney. It's very important to stress the importance of proper fixation and car seat safety in children. What happens if a child is not in the appropriate booster seat? The lap belt rides up along the stomach instead of around the hip where it can absorb the force. A chance injury can occur without a fracture. This is another injury, same mechanism with a seatbelt. One does not see a fracture on CT scan, but sees widening of the spinous process. In this case, there's significant ligamentous damage that becomes apparent on the MRI. Is there a difference between these two injuries? The first is an almost exclusively bony injury, and the second one is primarily ligamentous. The bones will heal as long as they are braced well. Ligaments, not as much. So in these cases, we can decide, is this something that will heal in an orthosis or something that requires surgery? For unstable ligamentous injuries, I think the risk of failure of external orthosis is high, and I would recommend surgical correction and stabilization. This is the ligamentous patient that we stabilized at the level of the injury. A year after surgery, they had robust bony fusion, recovered quite well. Properly secured children have a 70 to 80% risk of reduction of injury and a 28% risk of reduction of death compared to seat belts alone. People that deal with pediatric trauma realize that prevention is paramount compared to treatment. It is very important to be active in the community, as this makes a significant difference in the ability to survive a motor vehicle accident. Younger children have a higher center of gravity and a less developed iliac crest. Therefore, the lap belt tends to ride up along their stomach, where it does not provide much in the way of safety. Again, if one sees a seatbelt injury, it's very important to recognize the high risk of abdominal injury that may occur. This is another case of a 22-month-old who was referred. This was further evaluated by a CT scan, which shows an offset, and an MRI, which shows significant ligamentous damage. As stated, it takes a significant amount of force to injure the thoracolumbar spine in a child. Without a known mechanism of action, such as a high-speed car accident, one needs to be very suspicious of the possibility of abuse. And that's what occurred in this case. This was further investigated and found to be a non-accidental trauma case. As we already stated, children can recover from injuries that adults could not. This patient was taken for reduction and fusion. We fused one level as the child was still very light. They fused well. CT scan showed nice bony fusion at 1 year. The child recovered all function. Placing screws in a young child may be difficult. In this case, the one that I just showed, we used cervical screws to instrument the lumbar spine. This is a 2-year-old child who had atlanto-occipital dislocation, and this was our bony fixation point. We had one pedicle in C2 that was 3.6 millimeters. Smallest commercially available screw is 3.5 millimeters. With modern techniques, there's now widespread use of navigation, and this has become very valuable in trying to figure out how to place screws in smaller kids. The upper cervical spine, C2, is really the base of any construct. It is the only bone that will be large enough to accept a fairly large screw if one is trying to fixate to the cervical spine, to the skull. In this case with navigation, one technique that I believe is important is to place the reference frame on C2. It is generally the only bone besides C7 that's big enough to hold a reference frame in a young patient. The cervical spine in a baby is very mobile. If one places the reference frame on C7 and then tries to instrument C2, you'll often deform, move the body, and therefore have inaccurate navigation. If you are able to place it on C2, then if you move C2, it will maintain a consistent relationship and hopefully continue the accuracy. With any navigation, it's very important to always reference it with visual expectations of the anatomy. I have found that angling this superiorly allows for a good angle to place the screws. The translaminar screw is placed with a modified Wright's technique. This technique involves trying to place a screw through the lamina without violating the spinal column. We make 2 pilot holes, one on the entry point for the screw and one on the exit point. We then connect these with a pedicle probe. By finding our exit point, we know that our pathway does not go into the spinal canal. We then use a tap to thread the inside surface of the hole and then place our screw. This can be done freehand and generally does not need the navigation. One of the advantages of a translaminar screw in C2 is one can put a very relatively large screw into a small space that provides a tremendous amount of stability. If one places a lateral mass screw in C2 in a 2-year-old, you're generally using the smallest screw and getting only a few threads into the bone. It's generally an 8 millimeter screw. With a translaminar screw, one is generally putting in about a 20 millimeter screw and getting a fair amount of bony bicortical purchase. I find the construct of a unilateral pedicle screw and a contralateral laminar screw to be very useful in very young children. A note about steroids. In the original trials looking at methylprednisolone, it is important to remember that pediatric patients were excluded and they were not studied. Steroids and spinal cord injury is a very contentious subject. Current recommendations do not support the routine use of methylprednisolone in adults, and they have never been supported or studied thoroughly in children. In summary, it's important to recognize specific injury patterns and specific concerns in pediatric patients. Clearing the cervical collar is quite difficult. The multidisciplinary pediatric cervical working group provides a very thoughtful and very good framework for an algorithm to try to perform this. It is always important to recognize that no algorithm will cover every case and that clinical judgment and good diagnostic skills are quite important. It's very important to recognize specific injuries in the thoracolumbar area and especially the possibility of concurrent abdominal injuries. Unexplained hypotension in a trauma patient is a potential sign of a spinal cord injury. Unfortunately, it's very important to suspect abuse, especially in infants, especially without a known mechanism of action. In shaking injuries, there's often injuries to the upper cervical spine, which may be fatal. There are a number of references that I would recommend anyone with an interest in treating pediatric trauma to review. A number of these are listed and also listed in the chapter. Thank you very much for your attention.